This is the Psychcast by MDedge, where we bring you interviews with leaders in the fields of psychiatry and psychology, some masterclass lectures, and inspiration, with new episodes dropping on Wednesdays. I'm the voice of MDedge Podcasts, Nick Andrews. And I'm joined this week, as I always am, by the editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris. And Dr. Norris, we are going to be talking about neuromodulation and pain. But before we get to that, we'd just like to check in and see how you're doing and see how you're doing fending off the July heat. Because last time you dropped the most egregious truth bomb I've ever heard, which is that someone hates watermelon, which is an absurd revelation. Absurdity. Unreal.
Yeah. I actually brought that up to my family. I said, I mentioned that in a podcast and everybody was just like losing their mind. But no, watermelon is just not good. But I'm pleased to say in my house now, we've got some mangoes, some other things, some peaches, some like not offensive things. But I mean, no, watermelon. Again, I'm waiting for folks, anyone in the Psychcast, any of our audience. I mean, if you dislike watermelon, look, give me a shout out or something like that. Yeah. Don't let me stand here alone.
You can tweet at us. It's at MDedge Psych. Dr. Norris is not a big Twitter guy, but you tweet at us. You can send us an email. If you'd like to write a dissertation about why watermelon is bad, I invite you to do that. But you know why no one's giving you a shout out is because you're like the only person with this opinion.
Well, I am convinced I am not the only person with this opinion. I mean, we need to shout out to some of our other podcast brethren who have who've been on the show or things of that nature. I'm thinking about my cats in Canada or whatnot. I'm blanking on that. I'll get their name in a moment. But no, I'm not the only one, Nick. I'm convinced of this. There's a cadre of us out there that do not like watermelon. We just don't. I mean, we don't like it. I'm there. I'm waiting. The masses are going to come. They're going to rise up and they're going to say, "We're with you, Dr. Norris." Maybe that's going to encourage me to get on Twitter. But then again, Lord knows what's going to happen when people say, "No, you are the only person."
Yeah, no, and believe me, I will collect all of those responses, and we're going to keep score. We'll get into that as the summer rages on. But I wonder if colleagues in Chicago like watermelon, and that brings us to our guest, Dr. Philip Janicak, this week in episode 127. Dr. Janicak is the adjunct professor of psychiatry and behavioral sciences at the Northwestern University, and that is in Chicago. And the topic this week is pretty interesting: TMS, ECT, and other device-based therapies for treating pain, refractory pain specifically.
Mm-hmm. Well, you know what? This is a really interesting podcast. I mean, because for one, when we're talking about TMS, ECT, neuromodulation, things of that nature, I would not say that, I mean, it's now been around for a moment, but to hear Dr. Janicak really break it down and really start to, if you will, think about what TMS is, what it does. And also the thing about this podcast I loved was the backstory behind how TMS actually, because Dr. Janicak was one of I think it's fair to say, pioneers or early developers of TMS. I think he did some of the original clinical trials, if I'm correct. So listen to this podcast and listen to the story behind the story involving the patients and how this came about, and even Dr. Janicak's own story. So people are going to like it. This is one of those things where, in regards to thinking about TMS, you're going to get some different ways in which you think about it. Dr. Janicak goes into a bit more of a deeper dive at times in regards to theory and cutting edge approaches with TMS. So listen to this podcast. This is going to be a good one. This is good stuff.
Absolutely. And I guess what I was referring to in our intro, treating opioid use disorders, that's coming up on episode 128, depending on when you're listening to this, with Dr. Abigail K. And so that's what you can look forward to if you're listening to this as it drops. Something else, we do have a big announcement, Dr. Norris. Dr. RK, which is Dr. Renee Kohansky, and we've talked about her. We feel as if we've been kind of just burying her at the end of these episodes as a way to wrap up. But we know with the way the podcasts work, you try to get as much in, but maybe you can't finish an episode. About 70% of people listen all the way through the Psychcast. But for those that don't, who miss Dr. Renee Kohansky, thought, well, what are we doing? So we're going to start dropping her clinical correlation segment, which is what it's going to be called now, on Mondays throughout the month. And it's going to be 10 to 15 minutes, and she's going to be able to explore a full thought, no more part one, part two at the end of an episode. And what she does is kind of remove herself, not a 30,000-foot view and not a micro view, but just a little bit above the picture, and she can relate to what's going on in the clinic. Some of her favorite things have been, why it's important to take a patient's weight and, what's going on, how does psychiatry can relate to what's going on in the world in terms of movies, in terms of COVID, in terms of stress. So really exciting news that she's going to have her own show.
Okay. Exciting is an understatement. So this is great. It is, I mean, with Dr. Kohansky getting her own show, it's all I can say is that, brilliant. Medscape, WebMD, MDedge. It has been a while in the making. I encourage everyone to listen to Dr. Kohansky's show. And again, this is just all part of this, if you will, what we're trying to do here at MDedge in terms of building this this platform of podcasts and information that serves folks. So let's just keep it going. And Nick, I'm really, really, really looking forward to this. This is going to make, it might actually make my Mondays not that my Mondays are bad, but it's going to add a little bit increase, boost to it. Like Dr. Kohansky.
Dr. Kohansky is going to be perfect on Mondays, and that's, part of the consideration. Start your week off with some positivity. So you can email the show at podcast@mdedge.com if you have a topic that Dr. Kohansky you would like her to cover, or if you have something that you want us to get into, podcast@mdedge.com is the way to do that. We love 5-star ratings and reviews on Apple Podcasts and iTunes. We take those into account. It's a great way to help other people discover the show. And just drop us a line. Tell us whatever's on your mind. I am going to keep score about the watermelon thing.
You better keep score. Speaking of keeping score, though, there's one quick thing I wanted to do. I just wanted to give a shout out to Dr. Henry Nasrallah and the folks in Current Psychiatry. For those of you that aren't really aware, MDedge Psychiatry is a blend of clinical psychiatric news and current psychiatry. If you all, I want to say it's the July 2020 issue. Please pick up this issue in terms of what they are doing in regards to what current psychiatry did in regards of a practical evidence-based review of COVID-19. I think you're really going to like this. This is a very, very good read. Clearly, you can go to the MDedge website and access a lot of this content. But look, go to extra stuff. Sometimes you just need you need the print version too. Do both. Get the digital and the album. Get both. I'm telling you, this is stuff that, for those academics out, you can take this and start teaching off of this. So, a lot of times I will do that with our current psychiatry articles. So I don't really, sometimes I want to give a little bit more of a plug to our colleagues and what they're doing in current psychiatry as well as clinical psychiatric news, but pick that up. They have really done some very nice things. And I love Dr. Nasrallah's commentary, his editorial about COVID-19. He gives you a lovely lexicon.
I think maybe we should do a bonus episode or an emergency episode if you feel that good about it. So I'm going to put the link.
I feel very good about it.
Great. Let's do that. I think maybe we want to do that for everybody. We'll put the link in the show notes. And if people if it does as well as we think it's going to do in terms of impact, then I think we should do that because we're still in the heart of this. Yeah. And so there's no reason to waste this. Yeah. All right. So we'll look into the response and maybe there will be a bonus episode about Dr. Nasrallah's commentary and the research into COVID-19 and the impact. That's a great commentary. There will be a link to this in the show notes because it's available now.
Okay.
So that's perfect. Right. Yeah, absolutely. So coming up right after this is the interview with Dr. Lorenzo Norris and Dr. Philip Janicak. Remember, links in the show notes, courtesy of Dr. Jacqueline Posada. You're listening to the Psychcast by MDedge.
This is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. We're pleased to have with us today Dr. Janicak, who's going to be talking with us about TMS and just really the different ways this treatment can be of use to our patients, as well as things that clinicians need to think about in regards to this modality. So, Dr. Janicak, welcome to the Psychcast.
Thank you for inviting me.
Okay. All right, so Dr. Janicak, I read your recent article in Current Psychiatry, and I was really, 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 really interested in hearing a bit more from you in regards to transcranial magnetic stimulation. I would encourage our readers, or listeners rather, if you haven't looked at this article and, if you will, Current Psychiatry, hopefully we'll put the link to it in the show notes. I think it's going to be informative, and I think it's going to make you think about some things about transcranial magnetic stimulation that you may not have been aware of. But we have Dr. Janicak here to talk with us about it. So, Dr. Janicak, if you would please, could you give us a little bit of an overview of when we're talking about therapeutic neuromodulation, if you could give us a bit of an overview about what that means and what is it that clinicians need to be thinking about when we use that term therapeutic neuromodulation?
So the term refers to the use of device-based therapies, all of which in one way or another alter or modulate neurocircuitry within the central nervous system that we think are implicated in the pathophysiology of major psychiatric disorders. The lion's share of the data so far has been with major depression, unipolar, but there's also some data for bipolar depression, and there are data for other psychiatric as well as neurological disorders.
Dr. Janicak, can you maybe walk us through a little bit, because you have a really long and storied, if you will, history with transcranial magnetic stimulation. Could you maybe walk us through a little bit of the initial evolution of TMS over the past 25 years or so?
So in the 1980s, Anthony Barker in Great Britain was studying this particular device as a probe of the central and peripheral nervous system. And there was some thought that it could also be applied as a potential therapeutic strategy. And some of that evidence came from the fact that imaging studies were showing that certain areas of the brain, such as the left dorsolateral prefrontal cortex, had decreased metabolism and blood flow, and it often coincided with significant depression. And they also noted that when they applied TMS to various parts of the peripheral and nervous stimulation, central nervous, that's a mistake, we should repeat that, central nervous system, that they could actually reverse those kinds of phenomena.
Mm-hmm.
So people like Mark George, who's now at South Carolina, was studying with Dr. Barker at that time in the 80s and early 90s, and they began to think in terms of it now as a potential therapeutic strategy. So in the early 90s, a few small studies were done with major depression, and they showed remarkable benefit. And perhaps even more remarkably and very persistently throughout the history of TMS is a very benign adverse effect profile, which you can rarely say about any of the treatments that we provide our patients. So it was working in patients who didn't benefit from medications or psychotherapy and was causing fewer adverse events. That led to larger and larger studies, including a series of studies comparing it to electroconvulsive therapy. To my knowledge, there are now 12 studies that are published in the world literature comparing the two modalities. All except one was conducted here in the United States, and I did that when I was director of the inpatient psychiatric research program at the University of Illinois in Chicago. And myself and my colleagues conducted this trial. These are all inpatients who were considered by their clinicians appropriate for electroconvulsive therapy, were consented to be randomized, obviously not under double-blind conditions, to receive either a standard course of ECT or to receive a trial with this newer therapy, transcranial magnetic stimulation. And while it was a small pilot study, the total sample size was 32, we found that the overall outcome in these patients was quite comparable, and the only way they were differentiated in any significant way was far fewer adverse effects, particularly cognitive deficits, which were virtually absent with TMS, but as you probably are well aware, can be significant with electroconvulsive therapy. That led to my being introduced to the pivotal study that was conducted by the first company to make a device that they wanted to put on the market for depression. And I was a principal investigator at my site at Rush University in Chicago at that time. And that study included 301 patients and was by far and away the largest study ever conducted with TMS. It had 3 phases. It had a 6-week double-blind sham-controlled phase. It had a 6-week open-label phase for non-responders in the double-blind phase. And then it had a 6-month durability of effect phase. And the overall outcome found that there was a significant difference favoring active transcranial magnetic stimulation to a sham procedure in the double-blind period of the study, and in those patients who were then given open-label TMS as well. And that effect was maintained in about 84% of patients out 6 months, taking only a single antidepressant drug for maintenance purposes. And when I say was maintained, that means about a third of those patients showed some worsening of their depressive symptoms, and so they had TMS reintroduced on an as-needed basis. Average number of return treatments were 14 for this patient group. And if you include that group altogether, there were only 13% of patients who relapsed in the first 6 months, and the rest of the patients were able to maintain their benefit. So it was by standards of a device-based therapy, a very large study. It went through the FDA process and was the first of the TMS devices to be cleared for treatment of major depression, and that was in 2008. Okay. Subsequent to that, there are now at least 6 additional devices, all of which have different capacities and ability to produce different types of parameters that are involved with TMS to see if they can improve the efficacy of the treatment and perhaps make it more efficient by shortening the time frame, because it's a time-intensive process right now. Most patients have to be receiving daily treatments for 4 to 6 weeks, Monday through Friday schedule, and then some tapering sessions after the 30 treatments. So that's a 9-week process with some other alternative parameters, such as theta burst stimulation, which you and I talked about briefly before. You can reduce the course of treatment down to 1 to 2 weeks now in some studies. And there are a couple of devices now that have been cleared by the FDA to adapt the theta burst procedure as well.
Okay. Wow. Again, thank you so much for that overview. I mean, fascinating that you essentially were there at one of the pioneers and there at the start. Let's delve a little bit into that, because I'm personally interested in that. Was there a point when you were doing this, when you were working with TMS, where you were like that kind of moment where maybe you saw a patient or you just were seeing trends where you're like, whoa, this actually could be something different. This could be a true alternate treatment to ECT. Well, did you ever have like that moment where you're just like, oh my goodness, like kind of the hair standing on end, like this is going to be something?
Well, I can tell you about the first patient we ever treated with TMS, and that may qualify for your criteria.
Yeah.
This was a young man in his late 30s who suffered from bipolar disorder, because we included both bipolar and unipolar major depressed patients in our study. And he had a significant depressive episode, was hospitalized in a private setting, and was receiving a course of ECT. After 5 treatments, he had improved substantially, although not entirely, and opted out of any further treatments because of the cognitive issues he was experiencing. So he was discharged on medication maintenance, and within 6 weeks had a major relapse. He got referred to our research program at the University of Illinois, came in for a course of ECT. We told him about the study that we were doing, and he agreed to participate. So he gave us informed consent. This patient was kept on an inpatient basis because we obviously were using a treatment we had virtually no experience with, at least from our perspective, the first time we worked with it. We had trained on it with the people who made the device that we used, and they were from Great Britain, but we really had never given TMS to anyone. So he was going to be randomized, but he had some problems. He had some psychotic symptoms. For example, he wasn't eating, and he said the reason he wasn't eating is when he completed the suicide act, he didn't want to make a mess for the autopsy people, which I thought was a little psychotic in nature. He was losing weight dramatically, and he was not contracting for safety, even on an inpatient unit. So we had to monitor him 24 hours a day. We went through the randomization process, and to be honest with you, we're all hoping he was randomized to ECT because he was one of the sicker patients we've seen in a while. But unfortunately or fortunately, he got randomized to transcranial magnetic stimulation. So we gave him his first treatment on a Friday, and fortunately we all survived, especially him, but anxiety provoking for all of us too, to see how this would go. And really nothing happened. There was no benefit, there was no deficits, there were no complications. That weekend I got a call from my staff who said he was very upset and angry and did not want to participate in the study any further. And I said, well, obviously that's his choice, and I'll speak with him on Monday and we'll talk about what the next steps are. When I saw him on Monday in rounds, I told him that I was concerned about his difficulties over the weekend, and if he wanted to stop the study, that was completely acceptable. He said, no, I was just upset about that. And I said, well, what was upsetting you? He said, well, I couldn't even go to the restroom without a staff member standing outside the door with the door partially open. And I said, well, you remember when we asked you to contract for your safety and you said you would attempt suicide at your first opportunity? He said, yeah, that was pretty crazy, wasn't it? And I said to him, well, are you doing okay now? He says, yeah. He said, I have to say, for hospital food, the food wasn't bad here over the weekend. We quickly put him on the scale, and he had actually gained 2 pounds, and his weight had been going down for several weeks prior to that. So I gave him a second treatment on Monday with his consent, and he was heading north in terms of his movement. He was actually looking hypomanic. The third treatment, the device broke or we broke it. Not sure which one it was, but it stopped working. We had to ship it back to Great Britain, and it took about 7 days, I have to say. All due credit to the company in Great Britain. They got it, repaired it, sent it back to us, and it wasn't anything we had done, thank goodness, and it didn't put the patient in any kind of danger. So he came back. He had been doing nothing for about 7 days, and we said to him the way the study was designed, he had to go at least 10 treatments or 2 weeks if he was going to complete the study. Would he like to continue or would he like to stop? Because at that point, his mood was substantially better. He said, no, I'll continue. So we continued for an additional 7 treatments. At that time, he had 2 full weeks of treatment, and we looked at his follow-up Hamilton rating scale score, and it had dropped from a high of 42 down to 4.
Wow. That is.
I facetiously had staff lining up outside my door saying, "Can we be next?" So it was one of the most dramatic responses we've seen. Now, I've seen that again, especially with bipolar depressed patients, although I have to make the disclaimer that right now the FDA has not declared TMS for the treatment of bipolar depression, but in clinical practice, if insurance is not available and patients can pay out of pocket, it is being used for that purpose because it seems to be very effective for the depressed phase of bipolar illness as well. So that was our first patient, and I went from a lot of disbelief to becoming a great proponent of TMS after that, because we saw many, many other people do extremely well with TMS.
Well, thank you for sharing that story with us. And I mean, for some of our younger clinicians or practitioners out there, I love hearing that, if you will, behind the scenes or the evolution of a thing from the start. I started at my current role at the GW Medical Center in 2006. So TMS wasn't even approved as a treatment, even though clearly, as Dr. Janicak said, it had been around for a minute, for quite some time actually, but it wasn't approved for treatment until 2008, I believe. So I just find it fascinating for me to hear the evolution of this, of an alternative treatment. One of the few new ones that we had over the past couple of decades, if you will. So that was fascinating. The other thing that that really the story made me think about, and I'm sure many of our members in our audience can resonate with this, because ECT has been around for a good piece of time. I want to say since 1937, if memory serves me correctly. And I have referred patients for ECT, and make no mistake about it, in my humble opinion, well, not my humble opinion, the evidence-based ECT absolutely works. But as Dr. Janicak pointed out, I have had the experience of patients stopping ECT because of the significant cognitive side effects. And there's nothing more as a practitioner to see one of your patient getting better, but either due to memory or things of that nature in terms of the cognitive side effects, stopping. And for those of us who practice or who work with those with serious, severe mental illness, and notes, maybe you practice on an inpatient hospital's floor, maybe you worked in a unit or an environment or a clinic in which you're treating treatment-resistant depression. Honestly, I'd argue bipolar depression in and of itself is exceedingly challenging to treat, depending on where your patient is at. It's just so nice to have another alternative. So with that being said, Dr. Janicak, can you tell us a little bit? I mean, there's this one part in your paper that I really, we'll let that.
I'm sorry, that was my other phone. I turned it off.
That's okay. We'll just. Okay, cool. I'll pick it up from there. So Dr. Janicak, there was one part in your paper in regards to in current psychiatry that I really liked, and it was the question of TMS versus ECT. And I'll just quote it on here. The question often arises as to whether TMS is a viable alternative treatment to ECT. And I really like this part. I believe the answer is unequivocally yes and no. So could you elaborate a little bit on that for our audience in regards to TMS versus ECT and some things, just as you were doing before, like that you would consider in terms of which one you might recommend for a patient in terms of practical tips that we can give our audience?
So a little further down that paragraph, we do list some of the clinical characteristics that might encourage us to consider ECT before transcranial magnetic stimulation. But I also note in that paragraph, and I'll go through those criteria in just a moment, but I also note that until we get more definitive biomarkers, and we are making headway in that regard. For example, imaging types of studies that would allow us to separate out subtypes of depression. It's always going to be a clinical trial and error. And I've had many patients who I really thought should go to ECT, but they refused. And they said they wanted TMS and they wouldn't try ECT unless they gave them TMS first. And a substantial proportion of those patients did well with TMS, to my surprise, I have to say, while as many patients did have to go on to ECT. So what are the criteria I look for if I have a patient who has a serious depression and they're considering TMS or ECT, because I often do that type of evaluation at Northwestern, or whether they've come for ECT, but all of a sudden they've heard about TMS, could this be an alternative? If the patient has psychotic features, if the patient is acute and immediately suicidal, if the patient is not taking care of their basic needs, for example, adequate nutrition and hydration, if the patient clearly requires hospitalization to protect themselves or others from their behavior, those are all signs right now that would indicate ECT would be the preferential treatment for patients. TMS is not that level of improvement in that patient population as yet. That doesn't say we can't get there without causing the seizures and avoiding the cognitive deficits. We're just not there yet. And as you, I'm sure, gleaned from the papers you read it, we're still in the process. You mentioned that ECT has been around. It's actually been 80 years now that ECT has been available. That's one of the longest lasting treatments, not in psychiatry, but in all of medicine. So obviously it's doing something very good for some of our sickest patients. But at the same time, if you compare it to TMS, it's only been clinically available for 12 years, and we're still learning how to apply it, how to make it more efficient, how to make it more effective. And I think we're going to get to the point where we're able to use it as an alternative to ECT in an increasing proportion of patients who otherwise would go for ECT. I'm sure I'll get a lot of pushback from ECT proponents about this, but that's my belief at this juncture. We're moving in that direction. And I do not hesitate to use ECT when I think it's appropriate.
Okay. Now, and thank you for that discussion, Dr. Janicak. Going back to TMS and the various things that we can use TMS for the most part, unipolar depression. But I wanted to get your view or your take in regards to the use of TMS in other conditions, and in one condition specifically, obsessive compulsive disorder. I can't speak for the audience or the listenership, but for me personally, I think every psychiatrist kind of has, or mental health professional has a bit of their own wheelhouse. I tend to be, I would say I'm pretty okay with bipolar and mood disorders. I actually, I want to thank my mentors and colleagues at the Bronx VA associated with Mount Sinai, giving me all my training in personality disorder. So I'm very comfortable with that, as well as unipolar depression. But I'll tell you, I have a tough time with obsessive compulsive disorder. That I have not had myself personally great success in regards to.
I wouldn't be so critical of yourself. You're doing well with me so far.
Well, thanks, Dr. Janicak. I appreciate that. But I
have to tell you that obsessive compulsive disorder is something my wife accuses me of almost on a daily basis. But after 45 years, she's learned to live with it.
Oh,
but
wow.
I don't work with obsessive compulsive disorder patients in general, but as you alluded to, subsequent to the 2008 clearance by the FDA of the first device for TMS, just a couple of years ago, a second device, the so-called deep stimulation coil TMS device, received clearance from the FDA for obsessive compulsive disorder based on a large study comparing it to sham TMS. And using the Y-box, the Yale-Brown Obsessive Compulsive Scale, which is the primary outcome measure in almost all OCD studies, it shows a significant improvement. And if you have patients with severe disabling obsessive compulsive disorder and they're not benefiting or can't tolerate standard treatments, I mean, they don't have a lot of options. They have deep brain stimulation and they have neurosurgical procedures. Otherwise, these people live totally disabled lives. They have significantly higher suicide rates than the general population, equaling or exceeding people with major depression, for example. And they're basically, they're non-functional. That type of patient can do extremely well with some of these more invasive procedures, but it's really encouraging to see that as a step along the way, if medication psychotherapy don't work, there may be an option with deep stimulating TMS. Now, I'm not sure there's a difference between using a deep TMS stimulator and a surface coil, single coil device for TMS, whether there would be a difference favoring deep TMS. The only reason deep TMS got cleared by the FDA is because they did the study, but no one has done a study comparing the standard form of TMS to deep TMS to see if there would be a difference between the two of them in terms of DBS. So that's a question that remains unanswered in terms of OCD. So that's a question that remains unanswered.
Okay. All right.
So I don't know if that answers you. I don't know if that answers your question.
That absolutely answers the question. That absolutely answers the question. All right. My next question is, given what you've seen and your involvement in the history of TMS, but in TMS being, if you will, a form of neuromodulation, is there anything that you see, if you could look into your crystal ball, like down the pipeline, or anything that intrigues you in terms of like what maybe the next step in neuromodulation might be out there, or something that our folks listening to in the audience, there might be a medical student, there might be, again, because we got a lot of people who listen to the Psychcast. I said medical student, there could be a student in social work, there could be a student in nursing, there could be a student in, I think we've got folks in PTOT who listen to the Psychcast, and many people in different countries. But when you think about, when you look into the crystal ball, is there anything out there that where you say, that's exciting, or that's interesting, and let's see where this goes in the next 20 to 25 years? I mean, obviously TMS is one of those, but is there anything else that you're thinking about, Dr. Janicak, that maybe fits that criteria?
Well, I'd like to mention two things with TMS first, and then go on to some other issues, because I think it might be helpful for some of the audience that you just articulated. The first is that, I'm blocked for a moment. The first issue with TMS, oh gosh, I'm sorry, I blocked. Anyway, yeah, there are lots of things that are going on with the development of TBS. The other alternative disorders for which TMS may be helpful. And one that intrigues me a lot is because we were one of the first to report in our ECT study that in our battery of cognitive tests, looking at what TMS might do relative to patients receiving ECT, not only did we not see any deficits in cognitive functions, we actually saw improvements in cognitive functions, and they separated out even in the absence of lack of depression improvement with TMS. So we reported in a paper by my colleague, Dr. Martis, the fact that there may be a pro-cognitive effect with TMS. As you may or may not be aware, there are now several hundred papers in the literature looking at TMS as a potential treatment strategy for mild cognitive impairment, as well as for early Alzheimer's and other forms of dementia. That would be a dramatic improvement if we could get some of these patients early on in the course of their illness to reverse their symptoms or to forestall their symptoms, because obviously nothing else we have works. The big issue with Alzheimer's, as I see it, is much like with schizophrenia. We have to identify these people when they're at high risk before they're demonstrating clinical symptoms. Because by the time they're demonstrating clinical symptoms, it's a little late in the game, and then we get into kind of palliative treatments rather than preventative treatments. So that's an issue that I think should be important. The other issue that may be attractive to many of your listeners is, and an area that's being pursued actively, is the combination of transcranial magnetic stimulation with various forms of psychotherapy, specifically, more often, cognitive behavioral therapy. And it gets a little bit more interesting in that regard, because these studies can be done where you give a course of TMS, and in between treatments, you give your CBT sessions or your psychotherapy sessions, or, and what's being done increasingly, you give the cognitive behavioral therapy session or cognitive remediation session or cognitive enhancement session while the patient is getting treated. Remember, the patient's alert, they're awake, they're sitting in the chair, they're talking to the coordinator who's providing the treatments. We show them films and tapes of CBT and things like that, because it looks like, at least very preliminary, that while you're getting TMS, the neurocircuitry involved in receiving and assimilating and utilizing the information from these therapeutic interventions is enhanced. So you get a bigger bang for your buck. You may get a full course of CBT, quote unquote, in a 6-week course of TMS, for example, at some point. And people who are doing social work, counseling, therapy. We have them in our sessions actually doing their therapy sessions while someone's getting TMS in the hopes that they can get better benefit from both treatments.
Dr. Janicak, I want to thank you so very much for giving us that tour de force through TMS, and to all of our listeners. I mean, why wouldn't you want to go into mental health? I mean, we're talking about magnetic coils, dorsolateral prefrontal cortex. We just even blended it with my favorite therapy, CBT, and we got a great patient story in regards to somebody improving. I mean, why people don't want to just practice nothing but mental health, I have no idea. So Dr. Janicak, thank you so very much for speaking with us, and maybe we can have you back on the Psychcast again to talk with us about more about neuromodulation. All right, as well as
I'd be happy to come back because I didn't get to your other question about what I see in the future as alternatives to TMS, and I apologize.
Well, thank you so very much.